Thank you, respected chairpersons. At the outset, I am thankful to the organizing committee for giving me an opportunity to discuss an important and a very common topic. Also, I congratulate the organizing team for making an elaborate arrangement for this conference, and more so for picking up very important and common topics for this two-day academic event. The first talk will be touching on the practical approach to anemia, practical approach as far as a clinician is concerned. As far as anemia, I think not only the medicos, even the non-medicos know everything about anemia, but then there is a lot to be explored about it. So as an introductory note, this slide is just to show us that how common this problem is. And it is said that every second woman in our country suffers from it. Very important cause of maternal death. It affects all the age groups, both the sexes. Yes, some section of our society is more involved in anemia, and that is the female section, and more so if the female is pregnant, because then the requirement goes up. Defining anemia is very simple, but sometimes becomes tough also. For all practical purposes, we take a low hemoglobin as anemia, although we have two more parameters in the form of a red blood cell count and hematocrit. They go hand in hand with hemoglobin in most of the cases. So, although we have three parameters, but the simplest parameter to diagnose anemia still is a low hemoglobin. And the most important point, as Dr. Madan has very clearly mentioned, that anemia is not a disease. It is just a sign. So, mentioning anemia as the diagnosis on the prescription slip is incomplete. Yes, if we mention nutritional anemia, iron deficiency anemia, that's a complete diagnosis. If we mention anemia, hemolytic, query this possibility, that's a complete diagnosis. So what this means? This means that this sign can be converted into diagnosis. It is a sign we can convert it into diagnosis if we investigate, explore the underlying cause. That is what is important, and we should be able to differentiate a term which is spurious anemia, which occurs in some special situations where the red cell count is normal, but the plasma volume has increased, as commonly happens in the third trimester of pregnancy, or maybe in congestive cardiac failure or some other medical conditions. What is erythropoiesis? Just briefly I'll touch this because this has got a correlation with our approach. Erythropoiesis is nothing but the process of manufacturing unit, how the RBCs are being produced. That process in the bone marrow is called erythropoiesis. And remember, this process involves three things. One, it needs the factory for production, and that factory is the bone marrow. It needs the substrate, the raw material. If we don't have raw material, there is no use, you can't produce anything. And that raw material is in the form of iron, B12, and so many other things which are required for this. And then thirdly, we need a stimulus. We need a manager to look after the factory. We need a supervisor to keep everything right and give a stimulus to the workers. And here, our stimulus is the erythropoietin, which we get from the kidney. This is a diagrammatic representation of what happens in the bone marrow, how this final erythrocyte is produced, starting from a very basic stem cell, that is a pluripotent stem cell. We call it pluripotent because it has the potential to go into any side. It can go into the platelets line, it can go into the leukocyte, it can go into the erythrocyte. And after it gets committed from the pluripotent stem cell, it gets committed that yes, now I'll go to the erythrocyte series. And then it has to go through various stages of early erythroblast, intermediate, late erythroblast, normoblast, reticulocyte, and finally what we have, the erythrocyte, that is the red blood cell. And if you ask me, out of this diagrammatic picture, in relation to the today's discussion, I would say that the most important cell for me here is the reticulocyte, the immediate precursor of the red cell. Why I am saying so, it will be very clear from the subsequent slides that why I am saying so. Now this is how the reticulocyte looks like, and there's no nucleus, and this is how the red cell looks like. So red cell is smaller in size than the reticulocyte, and there are just 3 important points to look for, although this is the job of the pathologist, but as a clinician we should know something about it, that there is no nucleus in the red cell, number 1. Number 2, in place of nucleus, we have a very pale white area in the center which generally occupies 1/3 of the total cell. This is normal. The shape is biconcave, and the lifespan is 100 to 120 days. This is the normal lifespan of the red cell, and this is how it looks like. In between we have the neutrophils, which are also important once we look for the peripheral blood film. Now this is grading of anemia. When we grade anemia, we divide the population into 3 types: males, pregnant females, and non-pregnant females. Why? Because pregnancy, we have a compensation as far as anemia is concerned. We have 1 gram of compensation. So severe anemia in a pregnant patient would be less than 7, whereas in male and female otherwise it will be 8 grams. So anything less than 12.9 in males, 11.9 in females, and again we have a compensation of 1 gram, that is 10.9 for a pregnant female, because here we expect the hemoglobin to go down because of the increased requirement. And as a clinician, it's not that when we come across a patient of anemia, we straightway start writing iron, B complex and all that. That is where the problem starts. So the most important point is the history. We should always start from history, because this sign is very much related to so many things. What is the diet of the patient? Is the patient taking any drugs, any desi medications? Even so many drugs in our field, they are causing anemia. Is the patient running fever? Any bleeding tendency? Bleeding might be revealed, might be concealed bleed. So after we take an elaborate history and we make up some mind from the history what we are dealing with, then we really confirm anemia. We look at the skin, although the mucous membrane is more specific for diagnosing the conjunctiva and the mucous membrane. And then we ask for the history of pica, which is a craving for some odd items. Pica in combination with spoon-shaped nails, we know this is called koilonychia. These 2 are very important features of iron deficiency anemia. The tongue, I'll show you 2 pictures of the tongue. Tongue becomes smooth, there is loss of everything over the tongue. There is no papillae over the tongue, and the mucous membrane becomes inflamed. There can be ulcers in the mouth. Jaundice, every one of us knows. If we have a patient of anemia with mild degree of jaundice, we always think of one thing, that is hemolysis. And all of the time would be correct. Of course, then there can be situations in some infections, you might have anemia with fever like leptospirosis, that's a separate issue. But then most of the times we will be correct in our diagnosis that yes, this is a hemolytic anemia. Patient might have bleeding tendencies in the form of petechiae, purpura, ecchymosis, thereby meaning that now this is a case where not only the red cell population, the platelets are also getting involved. This might be a case having some underlying problem in the form of might be some hematological malignancy. Similarly, that is the reason we ask the patient for any history of bleeding from the gums. Any anemic patient who is having bleeding from the gums, we start thinking of something wrong. Something wrong has gone in the bone marrow. As far as lymph nodes, liver, spleen, they are concerned, they are not the features of anemia as such. They are the signs of the underlying disease which is causing anemia. But they are important because, again, we are going to convert this sign of anemia into diagnosis. So we need their help. Sternal tenderness, from the very first class of medicine we are taught that sternal tenderness means everything gone. The bone marrow has been infiltrated by some foreign elements. It might be leukemia, it might be lymphoma, it might be multiple myeloma, anything. This is a bad sign. Blue line over the gums I have specifically mentioned because lead toxicity sometimes presents as microcytic anemia, and we are confused that it might be iron deficiency anemia. Actually, if we have this blue line over the gums, this is suggestive of lead toxicity. And the last feature, that is breathlessness, tachycardia, congestive heart failure, they are all the effects of anemia on the heart because the oxygen carrying capacity has now gone down and the heart has to work more and more to compensate for that. This is just to show how the tongue looks like in pernicious anemia. That original color has gone. It has become totally bald. The color has changed, lemon yellowish color, and this is what happens if you have a patient who is taking some drugs. The number 1 and number 3 are no longer being used now. They're practically obsolete, but then neomercazole, antithyroid drug, anti-carcinogen drug, anti-cancer drugs, and a very commonly used anticonvulsant, phenytoin. So sometimes in a patient of aplastic anemia, you might have this look where you have these patches. This is called leukoplakia, right? Now, we have a patient who comes to us. We know the patient is anemic. We don't want to put the patient to a battery of tests, no. But definitely, we are not going to stop short there. So, I'll briefly touch these two types of parameters. One is the quantitative parameters, and second is the qualitative parameters. I'll try not to bore you, and to make it very simplified, we'll just pick up one parameter from each of these two groups. So in the quantitative parameters, we have hemoglobin, packed cell volume or hematocrit, and the red cell count. In the qualitative parameters, we all know we have the MCV, MCH, and MCHC. But we will pick one each. So from the first group, we will pick packed cell volume, hematocrit, because hemoglobin is already there, it's low. From the qualitative parameters, we'll pick one, MCV, mean corpuscular volume. So out of these 6 parameters, we pick 2, and these 2 are going to help us a lot in the diagnosis of anemia. This is just a little detail about these quantitative parameters, and we should know about the hematocrit or the PCV or the packed cell volume, which is nothing but the proportion, out of the proportion of the blood volume, how much is that volume being occupied by the RBCs is the packed cell volume. Although the values are different for males and females, but roughly we should take it something like 38 to 45% is the normal hematocrit average. And then we have the hemoglobin and the red cell count. Red cell count, you know, is generally around 5 million per cubic millimeter. This is just to show you that we have very rough formula to equate this. If you multiply the RBC count into 3, you get the hemoglobin. And if you multiply the hemoglobin into 3, you get the hematocrit. This is just a formula. These are the 3 qualitative parameters, MCV, MCH, MCHC. I told you most important is MCV, mean corpuscular volume. That is, what is the average volume of the red blood cell? That is what is there. And we all should remember the normal value of MCV, that is 80 to 100 femtoliters. because this is going to help us in differentiating anemia into microcytic, macrocytic, and normocytic. So out of these three, rest we have the mean corpuscular hemoglobin or the mean corpuscular hemoglobin concentration. It's very obvious. If something is low, either the production is low, or the destruction is high, or there is some loss. This is very obvious. So that is why we have divided the causes of anemia into these three groups. Either the production of RBCs is low, so that means there is something wrong in the bone marrow in our factory. There could be some problem in the proliferation of cells. I'll just show you in the subsequent slides what all can happen in the bone marrow which decreases the production. Second is the increased destruction. The production is okay, but something is going wrong. So cells are being broken before their lifespan. That is called hemolysis. And the third is an obvious blood loss. Any hemorrhage occurring, maybe hemorrhoids, bleeding, anywhere, acute or chronic blood loss. So these are the three important groups of causes of anemia, and the hemolytic anemia comes under the heading of destruction. These two come under the heading of decreased production. Now why I am focusing on this slide is, you have seen the previous slide how the cell matures from a stem cell to a full-blown red blood cell. So for the bone marrow to manufacture a red blood cell, we need two things. One, we need proliferation. The cells should proliferate. And second is they should mature. If anything goes wrong in either of these two, you will not get a full-blown RBC from the bone marrow. If the proliferation is going on, but maturation is wrong, gone. On the other hand, if maturation is okay, but cells are not proliferating, gone. So we have to focus on these two as far as the production is concerned, and on this as far as the destruction is concerned. So this is just a revision. So in the proliferation, we can have damage to the marrow, iron deficiency, a kidney disease, a chronic inflammation. In the maturation, we can have, most common is folate B12 deficiency, because these two affect in the nuclear maturation. In the cytoplasmic maturation, again we have the role of iron, we have some abnormal hemoglobins, and of course last is the destruction slide, right? So this is production hampered, this is increased destruction. So this is just a revision of what we have just seen here. This is how the maturation affects, right? So B12 and folate, they are involved in the nuclear maturation. And as far as the cytoplasmic maturation is concerned, in the heme part we have iron and this, and in globin part we have the the sickle cell and the thalassemia, right? So these are the causes of decreased production. Now, we have a patient and we want to investigate. Clinically, we have made up our mind that most likely this is the cause of anemia, but we want to confirm it. So, before we start our workup, there are 4 tests which have to be done for the diagnosis of the cause of anemia. And out of these 4, I will keep 3 as the most important. The 4th one we can ignore. So what are these 4? One is the reticulocyte count. I told you we'll give importance to this in the previous slide, I mentioned it. The second important is the MCV, mean corpuscular volume, which we discussed just now, the qualitative parameter. The third is the peripheral blood film. And 4th, which is not that important, but I'll just add in the list, is the red cell distribution width. So these are the 4 parameters. Very simple workup, very simple and cheap investigations. Patient doesn't have to spend much on this. And reticulocyte count. I told you in that diagram that I'll give the maximum importance to the reticulocyte. Why? Because it is telling us about our factory. whether our bone marrow is working normally. If our bone marrow is normal, reticulocyte count would be good. If our bone marrow is not working good, the reticulocyte count would be low, and this would be a bad sign, right? So anywhere we have a reticulocyte count which is going high and the patient is anemic, you need not worry. Our factory is okay, we'll handle up the other peripheral issues. So the reticulocyte count normal value we should remember, it is generally 0.5 to 2.5%, and then we have a corrected reticulocyte count depending on the PCV, and then we can calculate what is called reticulocyte production index. From the corrected reticulocyte count, we can calculate this. This is the corrected reticulocyte count. This is the PCV of the patient. This is the normal PCV. This is 5%. And why have divided by 2? Because this is the maturation time which a reticulocyte takes. And I told you that 2 days the reticulocyte remains in the bone marrow before spilling out. So this is basically, you need not remember this. The basic idea is to tell you that from the reticulocyte count we can calculate this, and reticulocyte normal count is 0.5 to 2.5%. If anything is more than 2.5%, our bone marrow is healthy. And this is the reticulocyte index, right? Now, this cell is so important that if the reticulocyte count is high, that means our bone marrow is okay, rather our bone marrow is working overtime. Our bone marrow is trying to compensate for the loss. So if there is any blood loss, patient is having hemolysis, or in patients of iron deficiency anemia, B12, folate deficiency, once you start the replacement therapy, you start giving iron, you start giving B12, the bone marrow again starts functioning and the reticulocyte count goes high. This is a good sign. This tells you that your treatment and your diagnosis are correct. Not only your treatment, your diagnosis is also correct. So reticulocyte count goes high, and in conditions where the reticulocyte count goes down, you see now aplastic anemia, very bad disease, myelodysplastic syndrome, bad disease, and marrow being infiltrated by foreign elements. We are trying hard, but the anemia is not improving. Reticulocyte count is not improving. Bad sign. And this megaloblastic and iron deficiency I have mentioned, this is before we give replacement. Once we start giving replacement, the reticulocyte count would start coming up. So you would see that in this list, majority of the diseases, they are not good diseases. Aplastic anemia is not a good disease. Myelodysplastic syndrome, again, this condition goes into a malignant transformation, not a good disease. And marrow infiltration, again, not a good disease. So this is just again to show you the importance of the reticulocyte production index. If it is less than 2, production is decreased. If it is more than 2, our production is okay, but there is increased destruction, right? Second test I told you, MCV. Normal value is 80 to 100 femtoliters. It tells us about the volume of the red cell, and less than 80 is microcytic anemia, 80 to 100 is normocytic anemia, anything more than 100 is macrocytic anemia, and in the subsequent slide, we should know the causes of each. We know microcytic anemia is generally due to iron deficiency, thalassemia, sideroblastic anemia, chronic diseases, they also cause, and lead poisoning at the last. These 4 are, of course, the most important. As far as macrocytic is concerned, most important is megaloblastic. And I hope everyone knows that when we talk of megaloblastic, we mean either deficiency of B12 or folate. So liver diseases also cause macrocytic. Alcoholics, we have a lot of alcoholics in our area. So alcoholics generally have anemia, and they're all macrocytic anemias. But I'll tell you how to differentiate this from this. It's very important to differentiate these two. But it's very simple also. And some hemoglobin diseases, marrow disorders, if there is increased destruction, again you can have a macrocytic anemia. But I would say these are the important causes. Normocytic, MCV is normal, 80 to 100. Patient is anemic. We label the patient as normocytic anemia. So, if you have a combined deficiency of iron plus folate B12, you can have normocytic anemia. All the chronic diseases, again, like microcytic, can give a normocytic picture. Rather, generally, they would give you this picture. Marrow disorders, again, would give you this picture. The third test, this is not a very important test. I told you very previously, will not give much importance. It only tells us the variation in the degree of size of the RBCs, and the only help, just for your knowledge sake, this test gives us is that if the patient is a microcytic anemia and we are confused whether it is iron deficiency anemia or thalassemia, so that is the only role it has. Normal value is this much. In iron deficiency anemia, RDW would be high, whereas in thalassemia, this would be normal. So I don't give much importance as a practical approach to anemia, but this is definitely sometimes a test helpful. This is the third important test, peripheral blood film. And see, all these questions are answered by the peripheral, simple a peripheral blood film. What is the size of the RBCs? Is it normal? Are they of same size? Are the cells of the same shape? Is the color of the cells normal? Are they of same color? Are there any certain special inclusion bodies in the cells? Not only this, it tells us about the leukocytes also. Any abnormality in the leukocytes, any abnormality in the platelets, the number of platelets and the morphology of platelets. So a simple slide prepared by a good technician and handed over to a good pathologist can give you a very good diagnosis, not only for anemia but so many other diseases. This is how hypochromia means pale looking cells. This is what the peripheral blood film in hypochromia looks like. This is a classical picture of microcytic hypochromic iron deficiency anemia. The cells, look, are small. And just look, the central pallor has now increased. It's not 1/3 now. It's occupying more than 1/3. Less of hemoglobin content. And anisocytosis, you know, the size of the RBC is different. We label it as anisocytosis. If the shape is different, we label it poikilocytosis. Now, we'll just spend a minute each on these three types of anemia: microcytic, macrocytic, and normocytic, because this is the crux of the story. Microcytic anemia, I told you, these are the 4 or 5 important causes. Now, we know for all practical purposes, microcytic anemia means iron deficiency anemia. But you might be in a problem. You are giving iron, taking it to be iron deficiency anemia, just waiting for the hemoglobin to rise. But the patient might not be having iron deficiency anemia. Patient might be having any one of these. So in these conditions, you might need certain special tests in the form of serum ferritin, serum iron, total iron binding capacity, and sometimes bone marrow is also needed. So out of these battery of investigations, which sometimes is needed in a microcytic anemia, I think the most important investigation here, again, just a practical tip I am giving you, is serum ferritin. Why? Because this is the marker of iron deficiency anemia. If this is low, you are very sure you are dealing with iron deficiency anemia and not the other 3 or 4. Because in others, the serum ferritin would either be normal or would be raised. And why I have mentioned bone marrow here? Because sometimes even in iron deficiency anemia, once you are really confused in the diagnosis, you might have to, in very selected cases, go in for a bone marrow iron study also, which is totally negative for iron, right? So these are some special investigations. This slide also tells you the same thing. So we generally say that the serum ferritin is less than 33 p moles per liter or less than 12 micrograms per liter. Serum ferritin is, I would say, the most important. This is again a repetition of what we have seen. And this slide is just to tell us that In microcytic anemia, sometimes if you have ruled out iron deficiency anemia, the results are serum ferritin is normal, then you have to look for the other 3 or 4 causes. And next important test is hemoglobin electrophoresis, because you might be dealing with a case of abnormal hemoglobin. You keep on giving iron, it's not going to be of any help. So you should go in for hemoglobin electrophoresis. Macrocytic anemia, megaloblastic and non-megaloblastic. Why I have mentioned this? Because these two are absolutely different groups. Megaloblastic means the bone marrow shows megaloblasts. Here there are no megaloblasts. But don't think that for a macrocytic anemia we have to undergo bone marrow. No, this is not what I mean. This is just to make the things clear. In my subsequent slide, I'll show you what is the value of this megaloblastic and non-megaloblastic, but we would not need bone marrow for every case of macrocytic anemia. So for megaloblastic, it is B12 and folate deficiency, which is generally seen in pure vegetarians, right? Persons on vegan diets who are not taking any milk products, dairy products, not taking any meat. And non-megaloblastic, liver disease, very common, alcoholism, very common, hypothyroidism, very common, and drugs, very common. Methotrexate, trimethoprim, hydroxyurea, right? Now, this slide will make us macrocytic anemia very simple for us. So suppose you have a patient of macrocytic anemia, MCV is more than 100 femtoliters. You label the patient as macrocytic anemia. Now you want to see what is the cause of macrocytic anemia. So what we'll go in for a reticulocyte count. Reticulocyte count is already with us. That is one of those important 3 tests which we have undertaken.
Excuse me, sir. I kindly request you to finish the talk soon. We are already out of time.
I'll take another 5 minutes. So the reticulocyte count goes high means there is some loss. Okay. Here, peripheral blood film is ordered. Now, normally when we send the patient for a peripheral blood film, we never write our provisional diagnosis. So I want to stress here that as a clinician, we should always write the provisional diagnosis so that the pathologist tells us whether he is having macrocytes are oval in shape or round. If they are oval in shape, take it for granted it is megaloblastic anemia. You don't need a bone marrow. This is B12 folate deficiency. If the macrocytes are round, it rules out B12 folate. But that is possible only if the pathologist knows that what you are looking for. He will concentrate on that shape of the macrocyte. So this is what I wanted to focus in this slide. This is just a repetition. Alcoholics, the important point is they have MCV high, but they are round macrocytes, not oval, unlike B12 folate. And the neutrophils are not hypersegmented, which is generally seen in this is the typical picture of macrocytic anemia, hypersegmented neutrophils. Cells are large in size, MCV is high. Third is the normocytic anemia. The most common cause is the chronic disease, renal failure, primary marrow disorders, and if you have a combined deficiency of B12 folate and iron, right? This is the routine evaluation, right? Again, see, we start with the reticulocyte count. This is such an important test. Now, we always talk of chronic diseases, but I think we should know which chronic. What do we mean by chronic diseases? Chronic inflammations, chronic infections, collagen disorders, malignancies, thyroid disorders, they all are a part of this. And most important chronic disease which we come across where we have normocytic normochromic anemia is the last one, renal failure. We should know we come across patients of chronic kidney disease, anemic, all of them are anemic. So these are just to show the causes of anemia. It could be iron deficiency or abnormal erythropoiesis because we are running short of erythropoietin also. Dimorphic anemia generally means normochromic and hypochromic mixture. So generally this picture is seen if folate and iron combined they are deficient as in pregnancy, or B12 and iron if they become deficient as in pernicious anemia. This is the last important anemia, that is hemolytic anemia, where the destruction is more, this production is okay, destruction is more, so reticulocyte count is high. Picture is normocytic, normochromic. But look here, why the reticulocyte count is high? Because bone marrow is trying to compensate. Bone marrow compensates 6 times. And once that limit of the bone marrow is crossed, the patient starts developing symptoms. So reticulocytosis is the most important feature of hemolytic anemia. These are some of the tests which we undertake to diagnose hemolytic anemia. Reticulocyte count, LDH is high, bilirubin I've told you is mildly raised, haptoglobin is low, hemosiderin appears in the urine, and hemoglobin also appears in the urine. Hemolysis, just briefly, can be extravascular, intravascular. This slide is a very heavy slide, but I am going to make it very light. Just to tell you that hemolysis can be extravascular, intravascular. As a clinician, patient comes with mild jaundice, anemia, we think of hemolysis. If the spleen is palpable, if the patient has splenomegaly, we are dealing with extravascular hemolysis. In intravascular hemolysis, spleen will not be enlarged. Rest, these are some of the tests. Hemoglobin appears in the blood, hemoglobin appears in the urine, and these would not be there in extravascular hemolysis. These are some of the special tests which are undertaken to further diagnose what is the cause of hemolytic anemia. These are some of the tests, and you know, in our MBBS classes, pathology classes, we used to be taught about osmotic fragility test. This is a picture showing that. This is how the normal bone marrow looks like, where the granulocytes are 3 times the erythrocytes. And look here what has happened. Erythrocytes, now bone marrow is due to some cause is trying to compensate, and it has increased its erythrocyte population twice than granulocyte. And look here what here. These 2 slides are in contrast. This is a pale looking slide, white looking bone marrow. It has lost its pink glue because this bone marrow is replaced by fat cells, pale looking cells, as happens in aplastic anemia. As a clinician, we should know what are the indications of bone marrow in a patient of anemia. This question sometimes comes in our mind. So any anemia which is not responding to treatment, refractory anemia, unexplained anemia, associated with leukopenia, thrombocytopenia, peripheral blood film is showing some abnormal looking cells. For any hematological malignancy presenting as anemia, we would need a bone marrow. And at the last, sometimes, I told you previously also, in iron deficiency anemia, you also might need this. This is just a logarithm. So to summarize, if hemoglobin is low, let's not start iron straight away. Let's ask for some tests which are very simple in the form of reticulocyte count, because this gives us information about the functioning of bone marrow. MCV tells us about the size of the cell. Peripheral blood film tells us about the morphology of the cells. And let's go in for a reticulocyte count. That is what is important. And anemia can be hypoproliferative, hemolytic, or hemorrhagic. If it is hypoproliferative, it can be either microcytic or macrocytic. If it is microcytic, it could be iron deficiency anemia. If it is macrocytic, most likely it is a megaloblastic, B12 folate. If it is normocytic, we should first think of anemia of chronic disease. And the take-home message is that these 3 tests, reticulocyte count, MCV, peripheral blood film, these are the most important, simple and inexpensive investigations to approach a patient of anemia. And remember, we should approach the patient of anemia so nicely that we don't miss some treatable conditions in the form of nutritional anemia, a GI bleed, a hemolysis, kidney disease, or a celiac disease. And at the last, I would say that if we come across any patient of anemia in his or her 50s or 60s age, and we are unable to find the cause, please don't miss a malignancy in the GI tract that might be presenting as iron deficiency anemia. Thank you so much.